It didn't come to me like, boom, Plavix, clopidogrel, 19 years.
He built a new one from scratch.
New findings, new drugs, whatever.
More hospitals, but fewer healthy people.
That was the right treatment.
Dell Medical School at University of Texas in Austin
The research system
spends more than $4.3 trillion every year.
the other country, and yet we're not healthier. What are you paying for the personnel that do that job today?
So the US healthcare system spends more than $4.3 trillion every year, yet still ranks as too low globally in terms of outcomes. We have more data than ever before, but less connection. More hospitals, but fewer healthy people. My guest today didn't just complain about the system, he built a new one from scratch. Dr. Claiborne Johnston, Clay as he's known, is the co-founder and chief innovation officer of Harbor Health, a Texas-based healthcare system redefining what patients' care should look like. Before that, he was the inaugural dean of Dell Medical School at University of Texas at Austin, where he designed an entirely new model of medical education. Today, we'll unpack how he's managed clinical precision, data science, and startup agility to fix the healthcare system, and what lessons every healthcare leader and tech entrepreneur can take from his journey. All right, Clay, welcome to the show.
Great. Well, thanks for having me, Abeer. That was quite the introduction.
Well, you spent decades in academic medicine from Harvard and Berkeley to UCSF, and then as dean at Dell Med. And now you're building Harbor Health, a system built to redesign care delivery. Take us back. What broke in healthcare for you personally that made you say, enough, we need to rebuild this entirely?
Yeah. It was kind of, it didn't come to me like, boom, now we gotta do this like almost impossible Sisyphean task. It really came in stages. So, I started as a clinician. So I'm a neurologist, and I'm focused on stroke care. And I got frustrated with how little we knew about what we were doing, and so I got into research because of that. It's a good way to not just treat better the person in front of you, but everyone else who learn, who can benefit from the learnings that you can produce. Then I got frustrated with research, and my initial frustration was just how slow and awkward it was. These are the innovations in the health system, and they take forever. And an example that I often come to is, early in my career, I said we should be using Plavix, clopidogrel, to prevent strokes in people at high risk for strokes, and it took 19 years to prove that that was the right treatment. 19 years, and I was part of all those steps to prove that. That was one little question. It wasn't like a brainiac thing to say, hey, this drug might work in this setting. But that's how hard it is to answer even a single question like that. So then I got into research administration. Like, what's wrong with our research system that it takes so long, that it's so awkward, it puts so many barriers up to us learning? And so that was sort of my, at the end of job, end of life at UCSF was a job. I was associate vice chancellor for research, and I ran the Clinical Translational Science Institute. Then I came to the realization that it really wasn't the research system, it was the health system that was dysfunctional. That in order to be doing the right things, the health system needed to be focused on caring about doing the right things. That the research that we were doing wasn't actually focused on the things that could yield the best health, the most health for people. And that none of it was supported by the health systems themselves. So industries generally invest in research to make themselves better, whether it's the auto industry or the cell phone industry or whatever. And they're constantly trying to improve. And part of that improvement too is making things more efficient, right? So you can produce that same product for less. That's an improvement as well. The healthcare system doesn't fund its own research. The hospital system doesn't support research. It sort of says it does, but it doesn't directly study the things that could produce better health for the people that are cared for in the system. And the system itself isn't even aligned on what it should be. Like for us, what do we want from a health system? We want to be healthier, right? And as you pointed out, the U.S. spends way more than any other country, and yet we're not healthier. So what the hell are we spending our money on? Why isn't there a better alignment on the expenditures of the dollars and the benefits that we achieve from them? So those realizations led me to say, okay, well, let's try it from scratch. Austin didn't have a medical school, so pretty awesome to be able to start one. And then you can sort of take a step back and say, we're going to rethink everything, and we're going to try to be as aligned with society's interests as possible. And what are society's interests? Society's interests are a system that really promotes health, that's constantly improving to try to promote health, and that is focused on waste in the system and reharvesting that waste to invest it in things that actually make a difference in people's health trajectories or lives, make them happier, better experience, anything else. And so that's what that was about. But then and you're right, I spent my entire career in, public sector, nonprofit world. But my realization was then this, we could show this. We actually made good progress at the med school and how easy it was actually to redesign care to make outcomes better and reduce cost. The problem we got into is getting paid for it. And in order to get paid for it, we really needed to control the whole healthcare dollar, the premium part of the insurance side, not just be a fee-for-service actor. The payers in the system, it's really hard for them. They're not incented to change the payment system or even to support innovations, even if they do improve health and reduce waste. And so that was my realization that led me to say, okay, what we did at Delmed was totally the right thing, but it cannot be supported unless on the private sector side, we have a system that's actually rewarding it. And that means tying the insurance to the care delivery platform. So that's the journey. So it's like a series of realizations. This is better. It's not the problem. And trying to look for what is the core underlying problem in the best tool and setting in which to address that problem. And then I should say, why is this in the for-profit world? It requires substantial investment. It's really capital intensive. We're not going to get that from the nonprofit world. And if it's going to succeed and scale, it actually needs to produce margins. And, that means the discipline that comes from being on the for-profit side is actually a positive thing in terms of ultimate trajectory.
Right. So I think from what you've described, it was almost like a experiential approach towards where you are at right now, in terms of sort of learning through each of the experiences that you've had that have gotten you to this point of creating this startup.
Yeah, that's right. I mean, I think, you could ask the question, well, why did it take so long? The reality is that great things are happening in all those settings. And the games on the ground are important games to play and are completely consuming for the people that are playing them. It takes some of that perspective and a deep understanding in order to rise up and say, okay, these are potential ways through it. And this is why we ourselves, who have been in this system, need to be part of finding the solutions. If we just say, okay, young person out of, Stanford Business School, we're going to let you as a, consumer and business person figure out how to make this work. Sometimes that's worked and done things well, but healthcare is so complicated, and understanding how the incumbents are going to block you and what their interests are, that requires really experiencing how things actually work on the ground at different levels. So I think that experience was was a useful adjunct to a team that can also look at it fresh and say, it shouldn't be done this way, it should be done this way. Why did anybody ever start building it that way? That those people are also important on the team.
So now that you've kind of taken on the entrepreneurship route in the last few years and are scaling the company quite aggressively at this point, what was the
Yes.
biggest unlock for you that you did not think of happening when you started this?
Yeah. The biggest unlock was so the in it's just a different way of pushing your ideas and then being able to implement them. In academia, you can have a great idea. You spend years and years even getting that thing funded. The cycles are purposefully slow, like NIH funding. If you want to do, test that new drug that I described, a lot of that has to do with just getting it approved by the NIH to move it forward. If you're trying to work with your hospital system, so many layers are put in place as barriers to change in those systems because they feel that they're already optimized to deliver what they want to deliver, which is margin and fee for service often. And so, you're butting against all those constraints. For us, there was a constraint in getting funding in the beginning, right? And getting refunded. But once we had that, we had resources and we were liberated to really do the things that were most important for us to achieve our goals, and in a way that was much less constrained. And so that's really been awesome. I mean, now we have more degrees of freedom in some ways in terms of the creative approaches that we can take to solving kind of the whole ecosystem, which is what we're taking on. And then we're constrained in other ways, like we actually have to we're not a public company and we have patient investors, but they're not forever patients. So we have quarterly earning requirements. Our burn rate has to be so and so, we have to be on a trajectory. All of those new constraints exist for us. But the reality is that second group of constraints, if we don't overcome those constraints, we do not disseminate. This can be, it's not an experiment where you show, oh, this stuff can happen, we can get this done. The reality is that the discipline, the new constraints that we have in this system are actually positive to the ultimate result of disrupting, changing, improving the health system.
Right, they're better aligned, basically. So let's kind of, and that's a good pivot into the next topic of the conversation for me. So let's look at Harbor Health. You've recently raised $130 million. That's impressive. Scaled to 50,000 plus members here in Texas, and you plan to triple your footprint. That's really rapid traction for a health system only a few years old. So from a technology and operational standpoint, what were the 2 or 3 key architectural decisions that enabled this kind of scale for you?
Yeah. Well, some of them aren't architectural, they're opportunistic. So, some of this is that quadrupling in footprint. We were able to acquire another clinic group, Village MD, sites in Dallas, Austin, San Antonio, and El Paso. And, the Village MD has struggled in its Walgreens partnership, and so that became feasible. That is quite a complicated thing to come together with another strong organization like Village, but they bring things to the architecture. Now talking about architecture, that they've done extremely well, and we bring other things that they haven't focused on. And so, the two together allows us to move much more quickly, and the synergies really do give us more than either entity alone could have. For us in terms of that architecture, so some of it is just like, what is it really about? Well, the way I see it is we're creating a learning health system. to other industries, like just think about how, factories work, or any, like Amazon, like why is it so good? It it has data, and it acts on that data, and it learns from it, and then it adapts and changes. Healthcare is changing all the time because of external, new findings, new drugs, whatever, but also pricing, and it's also changing because of the people you care about. Our ability to change as a system is extremely poor, in healthcare. And so what we're trying to do is really use data, organize that data, serve it up, make it more readily available to make good decisions by both members and by the clinicians and everybody else in our system that we pay, and then use that to create a kind of new standard for what healthy is. Um, and how do you make that work financially? There's a ton of waste in our system. And so how do you identify that waste, capture that becomes margin, but also it helps to support all these other investments that you're making in keeping people healthier.
Interesting. And when it comes to like interlopability with external systems, like with payers and hospital networks or third-party data sources, how do you approach that?
Yeah. So if we had endless resources, we might build our own electronic health record and some of the other sort of standard tools. We do not, that's expensive to build in the EHR. And so we chose one. And that can do a lot of the kind of core things. And they've gotten better and better, the electronic health records. So they do a lot of core things. They're mostly built though for fee-for-service billing, right? For billing, I do something and then you submit the bill and then you get paid for the bill. So that's really what they were designed to do first and foremost. And that's not really the game that we want to play. So we're building that on a layer that abuts the electronic health record. And what does that look like? It's kind of cobbled together, but no surprise, it uses the strong APIs that come from the EHR. It uses health information exchange data. So we pull in as much data as we can from other health systems because our people are bouncing around, right? So even though we're trying to give them a home and create good care, they're still get into some emergency room somewhere, and we want to have those records back. So we get those records in. And then what we do is to make that sensible, because that's like a ton of data, is that we use two tools. For that piece, what we use is basically generative AI to digest all of that and pull out the key information. And we do that pull out in a variety of different ways. So we vectorize all that data, and then we process it for various uses. So some can be a clinical summary for a clinician to see, hey, what's been going on with this person, including, things that happened outside. And some of it can be for the medical assistant. And more, we're going to be pushing it in front of the consumer directly. And then it can also be used to warn us about something. So we don't have to wait till somebody comes to us. And we've built another whole system on the claims data, all the billing data that happens in the healthcare system, not just our own, but across the state, that allows us to predict what's going to happen to someone. And that's incredibly powerful. Because ultimately our current system, the way it works is like you get sick, you schedule an appointment to see a doc somewhere, and then they react to that. And there are all kinds of problems with that. First of all, it's inconvenient, it's often delayed, and it's reactive. We can know what your issues are based on what you tell us or what's happening outside. We can anticipate the things that are happening to you, and we can give you other channels to interact with us, right? So, you could just text us and we could text back. And so that kind of responsive system, you get it in some other industries, right? A little bit. But we don't have it in healthcare where it would be extremely valuable. And the reason you don't get that, just to be so I just close the loop on that why, is so obvious. Like once you think about it, it's like, of course that should be the way it is. I should be able to talk to my system, my health system through and they should address my needs that way. You can't bill for that in today's healthcare system. There are all kinds of blocks for you. I mean, there are a few little workaround ways that give you a few dollars, but it but if we own the premium dollar, if we own your whole healthcare dollar, then we care. We want it to be as efficient as it can be for you so that you can be as healthy as you can be, because a healthier person is a cheaper person too. So our incentives are aligned.
Right. And thank you for covering like three different topics that I was going to ask you about. I know you've mentioned before that only like 10 to 20% of health outcomes are driven by clinical care, with real impact actually coming from what happens outside the clinic. So you kind of talked through about preventative care and what that looks like from the standpoint of your system, and then the segue into AI was super interesting for me as a AI nerd myself. So you're doing predictive modeling and AI based triage, as well as integrated analytics from the provider networks, like with your AI system. Is that what you mentioned?
Yes. So it's not, um, it is, I would say in some pieces are still in beta, some are deployed. So, but we're rapidly developing it. But yeah, that's right. All the systems that you just described are part of what we're building. The other realization is like waiting for a doctor's appointment is like not a good idea if you have something urgent going on. So we take for the most unstable people, we give them an option to be in like our intensive care unit, ICU for primary care. And that group uses a ton of AI tools to understand context, understand risks, and then we can serve up recommendations as well. And those can be, they're very specific to that person, but they're also specific to things that the LLMs don't know or don't have, like contextual information about cost and who the local best orthopedic surgeons are and for which conditions. And, we have all of that data as well. That we built from that claims data I was describing. So it gives you a really rich environment in which to create the tools to support the system. And then what I would say too is like over time, you right now the systems still are imperfect. They don't have all the data. They do get some things wrong. So you've got to have the right level of practitioner between that system and a person, unless you're using it just to engage on wellness or something like that.
Gotcha. But even from what you've mentioned, it seems like a almost like a behemoth task to achieve. Like, how did you design Harbor's data stack, like from EHR to member app to analytics dashboard? Because there's a lot of integration issues that happen, which most health tech startups face. How
Yeah.
did you get around that?
Well, I'm not the right person to get deep into the tech stack, but I'll say basically the modern EHRs are much better in terms of interoperability than the ones before. So specifically we use Athena, and the APIs are excellent, and so that's helped us quite a bit. And then we use Snowflake, so everything gets into the Snowflake environment, and we are diligent about how it's organized in that environment. And then we're on the AWS platform, and that gives us access to tools that makes it super easy actually to interface with a whole variety of different generative AI tools. And then the APIs allow us to push things back in. So we pull and push, and
Gotcha.
not everything can be pushed smoothly into the record. And so we do have our own Chrome extension basically that pops up next to the EHR, feels like it's within the EHR, that we use as an adjunct tool. So, I mean, and that's the beautiful thing as well, Abeer. It's like, you know, when we started, we didn't think we would be doing all this. But,
Mm.
as you know, it's just gotten way better and way easier. We started using machine learning from the very beginning. So 3 years ago, we were using machine learning on claims, which are, much in many ways easier. There's no natural language processing. It's generally cleanish data, and that got us partway there. But the Gen AI stuff allows us to integrate all that work into everything in the electronic health record, and it does it, like it does it really well off the shelf. It doesn't understand what it can't understand, so it practices like a standard doc, and a standard doc generally is trying to drive, not trying to, but somebody's pushing them to drive up the cost of healthcare. So there's a lot of waste in current practice, and there's very little knowledge of cost. And
Mhm.
so those are examples of things that we have to supplement into the system. And we've sort of figured out how to bridge that. Um, and so, yeah, it made it way easier to do this than we had anticipated.
That's a perfect segue to what I wanted to talk next. So, you built Harbor around a value-based care model, rewarding outcomes instead of procedures. And that sounds simple in theory, but operationally, it's one of the hardest things to execute. Like, what does it take from both a tech or data perspective and a culture perspective as well to actually run a value-based health system?
Yeah. Um, the most important part of it is alignment with the financial aspects of it. I hate to say that. Like cultural alignment with the clinical team, no
Hmm.
problem really. They don't want to do fee for service medicine. They want to, see 24 patients in a day, and to try to find procedures to do on people or extra labs or whatever to generate larger. They don't want to do that. They want people to be healthier. There is some parts of their training again that they can't help because of the CFOs still are there, and there's RVUs, there's relative value units, the way docs get paid, that encourage them to do more stuff. That's kind of ingrained, but they all really want to make people healthier. So that cultural aspect is not a problem. Um, in terms of the systems, as I mentioned, the systems really are built for fee for service, but they have these other tools, and if you treat them sort of like a database that documents things and task management system, then that doesn't have to distract you. And so then it's really the money. So let me just say, like for most places, value-based healthcare is about making people look sicker. And honestly, that is the way it works when you're not the insurer yourself. So how does CMS, how does Medicare Advantage work? Well, the government pays these places an amount that reflects how sick the person is,
Hmm.
and so there's a strong incentive to make someone look sicker. And in that is a game that everybody who's doing Medicare Advantage is participating in, and then CMS is trying to figure out how to moderate that game, and that's not making anybody healthier. It's just documenting and that they're sicker than somebody else thinks. And that's not the game that we want to play. So then that's again why, being your own insurer, this financial alignment is so critical. So when you're your own insurer, you've decided how much you're going to charge, you've collected that money, and then you're on the hook. And so then you've got to figure out how to get somebody healthier. Then the key is that you're not cutting corners, so that so you're paying less and they're not as healthy. And that is the other sort of piece of it. But for us, that's why we're also trying to figure out how do we build this long term, because a lot of things that make you healthier this year have their benefits in out years, not in this year.
Interesting. So if there was a health tech company or a tech partner that wanted to actually support a value-based system, what are like the three non-negotiable they should build for from day one?
Well, first of all, there are a bunch of them, and we've interacted with a bunch of them as well. And there's some good ones. Most of them are focused on the games of the day. So again, this coding game is one example. Um, I would say the issues that we've run into with these companies are there are a variety. One is, how easy is it to lift their system? How much interoperability requirements, how much customization, and how is that paid for, and how long does it take? So that would be one. And we've aborted some things that have failed that bar. The second is the payment model for it. They come in with a whole variety of different payment models. Generally, the ones that are most attractive are the ones where they take the risk on its benefit, not us, or at least that's shared. But sometimes they just want cash to do their thing, and often it's not justified. And that's really the third piece, that the thing actually works. And that's a problem, for everybody. They're in sales mode, and so we found we have to do deep dives into the technology. That the promise is always there, but the ability to deliver on that promise isn't fully realized. It's interesting because companies where that was true 2 years ago now are catching up. So it's sort of like, when do you hit hit these companies? But yeah, those are some of the examples.
Hmm. So
I would say too, like, one opportunity we see some general companies working in this space, but I think agents that have specific functions that appear like functions in healthcare, I think those will become ubiquitous and are quite useful and can be trained to around disparate system requirements. So, even like the call center reps and medical assistants, we're building, agents that assist medical assistants, but ultimately that will get to the next level. The front desk staff, the schedulers, the referral coordinators, those are all jobs in healthcare, and uh, agents will be doing those jobs in some period of time. I'm not quite sure how quickly, but so that, I think those are examples of companies where I think there's a huge need. If you sold that as my hourly rate is $1 an hour. What are you paying for the personnel that do that job today? Those are the kinds of payment models and execution that I was talking about before.
and I'd love to kind of talk through that a little bit more, but let me kind of zoom out a little bit first before we talk about agents, because that's an interesting topic. So we have AI models that are diagnosing faster than humans, variables predicting cardiac events, or machine learning, like you mentioned yourself, predicting remissions and things like that. So we've you've been in this space long enough to know tech doesn't transform healthcare alone, people and processes do. So from your perspective, what's the right way to deploy AI and automation in healthcare without adding noise or, fueling clinician burnout?
Yeah, that's a great question. I think without adding noise, so let me give you examples of where we've tried to use it to reduce noise and reduce clinician burnout. And we're not alone. They're one of the first, happy uses of AI in medicine was the AI scribe. So and there are a bunch of companies that are doing this now. We use Nabla, we use Suki. They're a whole mess of them. And basically, it just listens in the background, and at the end of a visit, it writes your note. And they're quite good. And why is that useful? Because docs spend a ton of time documenting, and in this reduces the amount of time and the amount of energy required to document, and so gives clinicians back some time. So that's like off the shelf. Not everybody, but a lot of folks are adapting those. Another example of something that we did was another thing that's really hard for clinicians is you're seeing a new person or you're seeing one of your own people in follow up, and you have to remember like who is this person and like what's happened to them, and hey, did they get that neurology consult that I ordered, and what were the results of it, and what we do is we use AI to digest all of that stuff and then to create a summary that's relevant for that provider in that setting specific to that person. So if it's a new patient, it's a longer summary that gives you, it's almost like having a junior doctor, a resident doctor working with you, and it serves up all that information nicely ordered by problem. And then the provider can look at that and go into the room and be ready. Whereas it might have taken them 20 minutes to do that for a new patient, complex new patient before, and they might have missed something, and much less likely to miss something with our system. So that's an example. So that's reducing friction, improving outcomes, and in making people happier, reducing burnout. Now what we're doing is that in that summary, we can drop in, hey, and did you know this person is actually at risk for a knee replacement surgery based on this part of their history? And physical therapy is probably a good idea for that. So we can drop in those things as well for them to look at and consider. And so start to change practice. And you see how that could create a learning health system, right? Like now the rules change on physical therapy. Maybe it's, a home thing that happens instead that's been proven, as opposed to an office physical therapy. We can slot that in, and then immediately that becomes the recommendation.
Right, right, right. Yeah, that I think that definitely kind of goes back to the same thing that we discussed earlier in terms of, you know, the the healing actually happens outside as well. It's not just like inside the clinic.
Yeah.
So I think, I mean, overall, like, the idea that for me, like this is true. Like many founders overlook this fact. Like healthcare doesn't need more tech; it needs better system thinking, which is what you've kind of developed, with the with this particular startup. So I think from a standpoint of scaling, and I want to come back to the agents that you were talking about, um, in terms of like what excites you the most about AI and what's coming up next. But so let's assume that you had $1 billion to invest in one area of digital health that real ROI and outcomes. Where would you place that bet and why?
Um, I think that the future um, is an, a super agent, basically. A combination of agents is the way to build it, but basically that in your phone you have the ability to connect to all your records organized and understood by an AI system that can anticipate and make recommendations directly. It knows what questions to ask you. In large part, it's replacing all the players in the health system, except for you'll need to, a real physician to, you can bet the AMA and the FDA is going to make a real physician review that and write the script. And you obviously need physical exam stuff. We're not ready for that. That's going to take a lot longer, the physical exam stuff. Then there's all the complex conversations and talking people through the future, the educational components. AI eventually will be able to do that as well. But today, that human contact is super important. Like if you look at the placebo effect, which is a real effect and has a pronounced impact on people's health, right now that's delivered through humans. we invest a lot in our humans, and so I think that's another function. So, but this tool, if you imagine it as being like with you all the time, and you can ask it questions, and it knows you, and it's making recommendations to you, it's pretty obvious once you think about that, that that's the way it's going to be. And and then that can also know all your genetics, right? Like right now, that's too complicated for anybody to really understand and serve up, but it's not too complicated for AI to do that. And so then, hey, you're about to fill a script for a drug that you're going to have a reaction to that that can identify that and make a recommendation for a new drug in a way that a doc wouldn't. And so ultimately, that's going to be a better system for promoting health. Um, that's the future. So, what if I had $1 billion? There are companies that are doing things around aspects of it, and so for us, we don't have $1 billion, so we have to figure out, can we partner and by the way, those other systems, that generative AI today, you just go chat with it right now. It's pretty damn good, actually. It's surprisingly good, but it doesn't have the context of you, and also it doesn't have your local context, and it doesn't understand your insurance and how that fits in. All these really important contextual data that also needs to get served into it. So that part of my $1 billion would be spent in how you serve that up and make that digestible in the LLM. It's not going to be you just feed that into the LLM and you make it because it's too local and it's too changeable. It's going to be more that that other data that I described is organized in such a way that it's easily pulled in to the Gen AI base. That the bigger models are digesting that data.
Right. So it's almost like essentially having a real-time component to the Gen AI aspect. So right now, obviously, it has just one context window. If you give it multiple context window with the devices, perhaps with your previous history, with other aspects, and it keeps on learning from what you're sort of living your life. So, and I think that's the cool thing about Gen AI models that exist right now, that they can get extremely personalized, right? Like where one human being cannot just focus on you and just work for you 24/7, you have that option now with Gen AI.
That's
Um,
right.
so I think, yeah, I mean, giving it more context when they're like, I mean, assuming this is similar to what Elon Musk is working on with the, devices that attach to you. So
Yeah.
that's like multiple context windows that are directly plugged into your brain. So do you see that as a, one approach to this, or?
Yeah, I mean, I think we've tended to, up until now, um, uh, over what did it anticipated more promise in that kind of data, sensing data and all that, than actually has been realized. So even
Mm,
like, okay, great, Apple spends, I don't know how many tens of millions on the watch being able to detect an arrhythmia. Like, how
mm,
many people has that actually helped? I don't know. Was that worthwhile? And how many false positives and how much extra stuff happened because of that. There's
yeah.
so much today that exists even in your electronic health records and in easy ways in which you could interact with the system that we don't act on and don't act on appropriately, either as people who don't want to be patients or in the health system. That there's tremendous opportunity just systematizing that and creating rational actions associated with those things. It
Wow.
then layering on top this other sensing stuff, yeah, it could help some, but I don't think it's going to be as impactful as folks have been thinking about.
Yeah. So you feel that's overhyped right now, the direction there.
I think, well, I'll just say, um, we got a lot of work to do. We have a, because think about it too, just from what I described, which I think once you see it, then it's like, oh yeah, of course. But then think about all the forces that will resist that.
Hmm, of course.
It's huge, and in particular the financial forces that resist it. But it's people, it's unions, it's professional organizations, it's provider groups, it's insurers. They're going to all resist aspects of that, right? And so unless they control it somehow, and then there'll be a battle for control, and then like no, it's like so you can see those are going to be the things that slow progress, and that's why we one of the reasons we built a fully vertically integrated system because we are the insurer and we are the provider,
Mm.
and so we have much more flexibility there to deploy things and test them and make sure they're working. And then the beauty of our system too is that we are much more aligned with the interests of the people we care for, and that to me was fundamental.
Hmm. I think that is definitely a key component of your growth, obviously, from where you scaled. So in terms of how at Tech Rebel we work with companies bridging that same gap from innovation to execution. So if a health leader or startup founder is listening today and wanted to partner with a technology firm, what would you say are like the key traits that you'd look for? Where like the biggest red flags that would make you walk away to work with a tech firm in this space?
Yeah, I think um, I mean, one is just, yeah, I think you've got to check on how well do they actually execute. So you've got to actually talk to our customers and understand that, like proven that they actually can deliver on the promise. The second is that they have to teach you things. If they don't teach you things, then it's probably not the right group. Um, so, and I think that could be it really should be teaching about the potential to build this in a future way, not just the obvious last prior version. Um, and I think getting that from the firm is really critical. Um, and then, yeah, I think time for delivery and understanding the core assets that they have to tap into and some experience with them. Those are all other important aspects.
So you mentioned a really interesting point earlier before I asked that question, that with the forces that are there in the healthcare system, you have to work with them. But when you started, your startup, obviously you were trying to disrupt and change the system. So where do you think is a good middle point for that to happen for like
Yeah.
for tech startups
So
that are looking to scale?
for us, we're on a runway, right? So we're ultimately we want to control everything, the insurance and the care, and we have insurance products as well. I didn't really talk about those, but those are just getting launched now. That's critical to our success, having our own insurance and having the incentives in the insurance push people to do the right things, which doesn't really happen in insurance today. It kind of goes in the opposite direction. So that's a key part for us for controlling and being able to disrupt. For those that aren't going all the way to, that's like capitally hugely expensive, operationally extremely difficult to deliver on. So what we're doing is like really at the extreme of big investment, high risk. In then at the other end are technologists to come in and say, hey, it'd be cool if we had this piece of technology. Those folks who don't have deep understanding of the health system generally fail. And then the issue isn't that could be a cool thing. I think, having a consumer perspective on what would work better in healthcare, that's, hey, I'd like to be able to schedule online for a visit. I'd like to be able to reschedule. I mean, like, of course. The issue is who's going to pay for it. If it was so obvious, that you came up with it as a consumer, then others have thought about it. And for some reason, there's a barrier to payment. And that's generally the thing that is most complex for those outside of healthcare who don't have a deep understanding of it to navigate. So the in between is really deeply understanding some segment of the economics and incentives of incumbents, and then going in and addressing a technology issue for that group. Then the issue is selling into incumbents, right? Or around incumbents. Just all these incumbents are big and powerful, so disrupting them is extremely difficult. So you're then selling into them, and so then what is it? How do you got to know that group extremely well? Like, how do they buy and how do they think, and like so that then becomes a big challenge.
Hmm. Well, I'd love to have more time to pick on all the topics that we've discussed, but honestly, this has been phenomenal. I think what I love about your work is it's not just theory, you're actually proving that healthcare system can be rebuilt from the ground up with the right mix of empathy from your experience, economics, and engineering. For our listeners, especially the healthcare leaders and innovators out there, Harbor Health is one of the most exciting models to watch. You can check them out at Harbor Health, and you can obviously follow Clay on LinkedIn. Is there any other way that people can get in touch with you, Clay?
I'm easy to find. People seem to have found my email address, whether I want them to or not. But I'm happy for your listeners to find it. So it's just clay.johnston at harborhealth.com. So people have, and obviously LinkedIn, people can reach out to me there, although I'm less diligent on responding there.
Perfect. Well, if you're a healthcare executive looking to build, modernize, or scale your digital infrastructure, you can always catch us on techrebel.com/health, where we help visionary leaders turn ideas like Harbors into operational reality. Clay, thank you so much for joining us. This conversation was a masterclass in how to redesign healthcare intelligently.
Thanks, Abeer. It's been a pleasure talking to you.
Thank you.